So, John, thank you so much for joining us today. Really appreciate it. Just in full disclosure, I am a DermTech shareholder in my personal account and a institutional fund that I run. But I just wanted to, give my newsletter subscribers and some of my Twitter followers a chance to, listen to this interview or watch this interview so they can learn more about DermTech as well. I did a write-up on the company about a month and a half ago, so I've been pretty bullish ever since I dug in. But let's just kind of start at the beginning. When did you join DermTech, and what exactly is DermTech doing in the genomic space for early melanoma detection? And we can talk about some of the other stuff.
Sure, thanks. I've been at DermTech for, gosh, almost 9 years now. Was really there at the founding stage when there's a handful of employees trying to capitalize on this interesting technology. And our goal is really to create a new category of medicine that we call precision dermatology. And that category is enabled by our non-invasive skin genomics platform. And what that means is we collect a sample of skin with an adhesive patch, so it's entirely non-invasive. And we can extract the genomic material from that sample, and we can do a variety of genomic analyses on that sample. We currently deploy to enhance early melanoma detection, but it's really a platform. And our goal is to really fundamentally change the way dermatology is practiced. Dermatology is really a subjective specialty that is prone to error and relies on invasive surgical procedures, and that drives cost in that specialty. And we think with our platform, we can make it non-invasive, more accurate, lower cost, and objective, and that improves the overall diagnostic pathway. And so we can apply it to many things, not just melanoma, other skin cancers, inflammatory diseases. And what we talk about internally is it's a rare opportunity when you can really make a fundamental change in medicine. Most technology in medicine is incremental. It's a slight improvement on what came before. And it's rare when you have these opportunities that really fundamentally change the way an area of medicine can be practiced. And that's what we're really offering. That's why we're so excited about it.
Now, for people who don't understand, these patches are about the size of a quarter, right?
Yep.
And the dermatologist gets them in a pouch of 5. And they would apply them over the mole, after cleaning the skin, obviously, right? Circle it and then send it back to you guys, and you guys process it in California.
Exactly. And what's unique about it is they apply 4 patches to any lesion. So, and that's just so we get enough. It only takes off just a layer or 2 of the stratum corneum, which is the very outer superficial layer of skin. If you put Scotch tape on your skin and you hold it up, you'll see a little bit of a film, maybe a skin print, we call it sometimes. That's just a layer or 2 of stratum corneum. You have many layers of stratum corneum. And we take off with 4 patches enough so that we can get enough genomic material to analyze it. What's unique is you can send the package, the sample back by standard FedEx. Even you could use the standard mail if you wanted to, because the sample is actually stable without any preservatives, no ice. The genomic material is cocooned in that cellular material, that skin material that we're collecting with the adhesive patch. So it makes it very easy to collect a sample and get it back to us for our analysis.
And then what's the turnaround time from when you send a report back to the dermatologist or medical professional?
We process a sample within 72 hours, and our turnaround time is anywhere from 1.5 days to 72 hours. And you don't really need to turn anything around. And with the test, we're doing anything within a week. That's the time that a doctor can actually schedule patients for appointments. So we have plenty of time to turn it around, especially with the speed with which you can do our product.
And the old way of doing this is you go to the dermatologist looks at your mole and says, that looks a little suspicious, let's keep an eye on it, or let's take a picture of it, right? And then if they think it looks suspicious, then they might order a biopsy.
Mm-hmm, mm-hmm. Yeah, so this is sort of the subjective visual assessment that the dermatologist does. He looks at the skin, and he's looking for actually the same criteria that patients can look at themselves, which are what are called the ABCDE criteria of a mole. It means is it asymmetrical? Is it changing? Does it have different colors? Is the border irregular? Those are the same things the dermatologist is looking at. Unfortunately, while they help identify melanoma, they're pretty poor indicators of melanoma. But our test is used on any lesion that has those sort of features, A, B, C, D, E. And there are many, many hundreds of millions of moles in the world, in the US alone, that have those funny looking features. But the vast majority of them, 95 to 97% of those, are never going to be melanoma. They aren't. So you really need a better way to rule it out. And that's what where our patch comes in. If you look at what's going on at the genomic level, which is that root cause of cancer. Cancer is caused by changes in the genome that cause cells to behave badly. If you can measure those changes, you get a much more accurate way to know whether that mole truly has melanoma. And that's what we're doing. And then it avoids the need for the doctor to get the scalpel out and cut unnecessarily on a patient. There are actually 25 to 30 surgical biopsies performed to find one melanoma. So all those other biopsies are basically negative for melanoma that they're performing. And we can rule out, we can reduce that by almost tenfold when our patch is integrated. So now it's only about 2.5 surgical procedures per melanoma found.
Now, what's the pricing for your patch versus doing a standard biopsy?
So our test is reimbursed by Medicare. This is public knowledge at $760 per test. It costs on average about $1,000 to adjudicate a pigmented lesion. And people often think, oh, well, a biopsy, they do a shave biopsy and send it to pathology. That can't be more than a few $100s. How does that work? Well, it turns out there's a lot more other costs that get put into the processing and evaluation of lesions. So many times after the doctor does the initial biopsy, the pathologist can't really tell if it's melanoma. Early stage melanoma is so difficult for the pathologist to diagnose because the changes he's looking at under the microscope are very subtle. More importantly, he's only looking at about 1% of the lesion. So he gets that sample and he cuts a very thin slice of that sample. It's only about 1% of the lesion. So he doesn't know what's going on in all the other areas of that particular sample that he's been sent. So there's a high chance if something bad has happened and it's not in his field of view, he won't see it. So pathologists will often say, you know, I can't really tell. There's some atypical features here. Just go ahead and remove it. There's still a low probability it's melanoma, but about 40 to 60% of biopsies that are initially biopsied have to go to a full excision. That drives a lot of cost in the assessment of melanoma in moles. And then you also have to factor in if you delay the diagnosis of a melanoma, even by a few months, the costs get astronomically higher. So when you look at all those costs, it costs about $1,000 to $1,500 to assess a pigmented lesion for melanoma on average. And so our test, even at $760 by Medicare, is a cost savings to the overall system.
So, I mean, this is obviously a win-win-win, right? It's a win for the patient, less biopsies. It should be a win for the dermatologist because then they can try to identify which moles are suspicious before ordering a biopsy. It's a win for the insurance companies because it's cheaper to do this before, you know, and hopefully rule out the more expensive biopsy. And we know it's cheaper to deal with skin cancer the earlier you catch it, right? There's I think a 99% recovery rate for melanoma if you catch it early versus a 20 or 25% recovery rate if you catch it later.
Exactly. Yeah, so you get it. This is all about early detection. When you detect melanoma early, you cure it 99% of the time, and that's where we play. We find melanoma at the in situ and stage 1A when it has that very high cure rate. It's just that is the most difficult the most difficult stage to diagnose melanoma. It's well known that melanoma is probably the most difficult diagnostic pathway, early melanoma in medicine. So they really need to apply the genomics to get an accurate result. And being able to get that more accurate result with genomics non-invasively is that added benefit of eliminating those unnecessary surgical procedures.
Now, if anyone looked at the DermTech stock chart and they go back to December, the stock popped when the National Comprehensive Cancer Network came out and kind of gave their stamp of approval on your smart patch, right?
Mm-hmm. So
how big of a deal is that? I mean, I think the NCCN, I think it's 30 cancer institutes that fund it. I mean, I assume the hope for you is that DermTech becomes the standard of care for dermatologists, that, you know, before you order any biopsies, let's do the patch first.
Sure, that's the holy grail for any new technology like this. And we would love it if it happened that way. I think there are a bunch of factors at the end of the year that really started to come together for DermTech. You know, when we really launched the product, which was really right after that Medicare coverage, we started to scale our sales force. That was in February of last year. That was in the middle when the pandemic hit. And we had to put all our plans on pause until really in the second half of this year. The payers kind of went on hiatus. They weren't really looking at new technology because they were worried about COVID. But we kept, executing. And we also completed an important clinical study we called the TRUST study, which showed the test in the real world has what's called a 99% negative predictive value. That means there's a less than 1% probability that we miss melanoma when our test is negative. And we did a real world study to look at that and show that that is the case. A lot of companies calculate their NPV or PPV, but we did a real world study and showed that it is 99%. We also got some payer wins in the later part of the year because payers started looking at the technologies, new technologies again. And then we got the NCCN cancer guidelines, as well as we did a significant financing to really capitalize the company to seize the opportunity. And I think that confluence of factors really put us on the map and really rose the visibility among investors of DermTech in general.
So in terms of the payers, I know a couple of the big ones that I've obviously seen. So is Blue Cross Blue Shield of California and Blue Cross Blue Shield of Texas, right?
And Blue Cross Blue Shield of Illinois. Those are three of the largest Blues plans in the country. We think that's an important.
But there's another 30 on top of it. So I mean,
so we're still in the very early phases. So, it takes companies in this space about 2 to 3 years to get to 80% coverage. So there's about 280 million Americans. That would be about 280 million Americans in total in terms of covered lives that you're shooting for. We're now at about 85 million lives. So we've got a lot of work to do there still. But all these things we're talking about, more evidence development, the NCCN guidelines, driving adoption is a big important factor because payers don't want to cover tests that don't get used.
Right.
And the more patients that are benefiting from that test who are their customers, they need to listen to that. So driving adoption is the way you get payers on board. And then we also are doing another economic study with Optum, which we think will be done by around the end of this quarter, which will be a very large study looking at 30 million claims to really show even more definitively the cost benefits of our technology. That'll be coming out. So all those things move in tandem to drive payers to start covering the test, which will grow our ASP and then grow our revenue.
Gotcha. Now, I know you have a couple products in the pipeline. Can you talk to us about PLA Plus and Luminate and when you might expect them to be available?
Sure. So the PLA Plus, that's kind of a second generation version of our melanoma test. And that test adds another biomarker. It's a mutation in a gene called TERT. And TERT is a very important biomarker for early melanoma. It's one of the early mutations that occurs in melanoma. What it does is it immortalizes cells. One key feature of cancer is that the cells can divide indefinitely without ever dying. And that mutation in that TERT gene is what gives them that immortality, if you will. So we're adding that particular biomarker, that mutation, to our PLA test. We call it the PLA Plus. And what it does is improves the sensitivity of the test from 91% to about 95 to 97%. And that's a meaningful improvement. We're already very high, so getting incremental improvement in the sensitivity is important. And we also think doctors recognize that TERT is a key cancer gene, cancer-causing gene. So it will add some more credibility with the users. We expect to, we were going to launch that last year, but there were some supply chain challenges with COVID on the consumables that are used to run genomic tests, and because all the COVID tests are basically a genomic test. And so we delayed that, and we're gonna start offering that in the second quarter of this year.
Will PLA Plus replace the current PLA test, or will they both be available?
They're basically both available. People, when they order the PLA Plus, they're basically always ordering the PLA. The Plus means they're also ordering the TERT mutation, and probably most people will order both. So
okay. Will PLA Plus be any more expensive?
No, not really. There's a code for TERT that we could bill under. Whether or not we get paid for it by the payers, we'll have to see. But it's it's just a small additional cost to add that mutation that we look at in TERT to the overall cost of the assay. And we think improving the performance of the test is worth that incremental cost for us to run the test to add that marker.
Gotcha. Okay. And then Luminate, is Luminate more of is that going to be a DTC product?
Yes, we would call that a DTC LDT. So it will be ordered by a physician because we are looking at basically skin cancer risk and photo damage that the sun causes from UV rays. So, but the patients would initiate it. If they want it, they would then basically fill out a form, and then a doctor can order the test, and then they would collect it in their home, and we would send the results back to them after the doctor has ordered it. And that's a very interesting product because, cancer is all about early detection. And that's what's been going on for the last 5 to 10 years, is how do we get better at early detection of cancer? Because that's really how you save lives. There's all these wonderful late stage treatments, some phenomenal things going on in immunotherapy and targeted growth driver inhibitors. But really, if you catch it early, you don't need all those late stage therapies, and you still don't have a perfect survival rate with late stage treatment. So finding it early is the way to go. What I think you're going to see in the next 10 years is looking at pre-cancer risk. So can you pick up changes that are occurring that put people at elevated risk to develop cancer? And in some ways, that's what Luminate is doing. We're measuring UV damage to the DNA. The DNA, the UV light from the sun can cause mutations in your DNA. And if it causes certain mutations in certain genes that are called driver genes that can cause skin cancer, we can pick those up and quantify those and then give you a sense for how much damage has been done. And that is correlated. It's well known in the literature that's correlated with your skin cancer risk. And so that's what that product will tell you. It'll also tell you what kind of photo damage you're doing to skin through that exposure, because those are also related to that UV light. And we think consumers will want that test. There are many things you can do with that information. That's the most important thing about that test, is it provides actionable information. So it could be as simple as using better sunscreen or taking some supplements that help turn over your cells and get rid of those mutated cells or damaged cells, to topical creams that your dermatologist can prescribe that also take away those damaged cells, to photodynamic therapy or chemical peels or laser treatments that also get rid of those cells. So it's very actionable information that we'll provide with that test. So it's not just telling you, oh, I got high risk, now what do I do? No, here are some things that you can do based on your level of risk.
Right, and it gives the dermatologist a way to kind of prove to their patient that there is significant damage, and then maybe that patient will take them more serious and take the next step. So in many ways, you're creating additional revenue for those dermatologists, right?
That is a great point, Jonah. You get it. And I think there's an opportunity there. Yes. So I think the doctors will like the test. We will distribute the test into our professional channel too. We think dermatologists will want to offer it to their patients for those reasons. And we think patients will also want to get the test themselves. The interesting thing about some market research that we did is that with consumers is that they almost want an independent objective assessment because they're worried that the dermatologist might be just trying to sell them
something.
So they would like that independent objective information that a test like this could give them, that they could do on their own and then be able to take charge of their own health.
Now, how hard was it running the company and launching the PLA product in the middle of a pandemic? I mean, I assume that you need to get your salespeople into these dermatology offices, but if no one's allowed to go into them, it makes it kind of hard to educate these doctors, right? Or it did?
It does, and it's still a headwind. We still have limited access to the doctor's office because the pandemic is still with us. It's getting a lot better, and so we're optimistic that we're going to have better access to the doctor's office. It was a real challenge, and I'll tell you, it's still a challenge, but we've been able to grow through it, which is a testament to my management team and our sales managers, who are just the top of the cream of the crop when it comes to dermatology sales. Our whole commercial organization, they've really been able to manage through it. We switched to webinar training and virtual calls, and we've been able to grow very effectively despite the pandemic. and we think it will get better. But an interesting thing, a silver lining of the whole pandemic, is that the pandemic catalyzed the move to telehealth or remote delivery of care. And we've always had that on our radar screen, that we could offer our tests for in-home testing with a teledermatology, particularly a store and forward solution that we're working on. And when everything was shut down, we were the only game in town that could offer in-home melanoma testing, and patients needed it. And so at every major dermatology conference in the country, we had high visibility because we were the only solution to that problem when everything was shut down for about 3 months during the early days. And that's now catalyzed us to really move more aggressively into that telehealth solution for in-home skin cancer testing, which is what we're making some investments to do now.
Now, I'm sure one of the things that you're aware of is, doctors are probably very slow to adopt new technologies. They've been trained to do something the same way, and if they've been practicing for 20 years, they don't just, accept change very, very quickly. So how hard is it to, get over that hurdle and prove to dermatologists that this is a better standard of care, and it's in the patient's best interest to use the patch before, going right to the scalpel?
Yeah, I am a doctor, a physician. I trained as one, although I don't practice anymore. So I know exactly what you're saying. We do train a certain way, we learn things, and it can be hard to break those habits. This is ultimately about, you have to win both the mind and the heart. You win the mind over by giving good, high quality data and evidence, getting NCCN guidelines, things like that. And I think we've done a good job at that. Then you have to win over their heart by showing that this is helping them, that their biggest fear is that they're going to miss a cancer that they might have looked at. And so and they need to understand that we're there to try to help them, and that is not a threat to the way they practice. I think as they start to understand that, we begin to win over their hearts, and then that's when you see their utilization go up. I'm not saying it's going to be easy, because dermatologists are a tough customer, and they do train to look at things visually, but we are making great progress, and I'm confident that we're going to be able to grow our business very effectively within the dermatology community.
In terms of growth, are you guys just focused on the US right now, or are you looking at international growth as well?
The US market is gigantic, right? In the US alone, there are about 4 to 4.5 million surgical procedures to diagnose melanoma each year. For non-melanoma skin cancer, there are about 12 or 13 million procedures to make those.
So those are the other, right? There's 3 forms of skin cancer. Melanoma is the most deadly, right? And then the other 2 are you referring to?
The other 2 are called basal cell cancer and squamous cell cancer. They're the most common form of skin cancer. There are about 4 to 4.5 million of those diagnosed every year. Those are the ones that are primarily, all those cancers are caused by sun exposure, but most prominently the non-melanoma basal and squamous are caused by sun exposure.
Are they deadly? Are they as deadly as melanoma?
They aren't as deadly, as aggressive as melanoma. In terms of sheer numbers, it turns out that squamous cell skin cancer is actually killing more patients today now than melanoma is on an absolute basis. That's because there's 1 million of those diagnosed, and it causes about 20 to 30,000 deaths each year, whereas there's about 200,000 melanomas that cause about 10,000 deaths in the US. But so on an absolute number, yeah, squamous cell cancer is becoming a problem. And that's why, Luminate's important. The early detection with our carcinoma product, which will be the test to detect those other non-melanoma skin cancers, will be important. But that market opportunity is so huge. We really right now we're focused in the US to get the job done here.
Right.
We do have opportunities in outside the US, Australia, Western Europe for sure. But we want to make sure we get the job done first in the US, and then we'll begin to expand beyond.
Because I don't think the patches for those other skin cancers are, being priced into your stock right now. So any idea when those genomics patches might be available?
So our target is to have the carcinoma test available in the first half of 2022.
Okay.
We're working to develop that product right now, making good progress on that. And then the Luminate we want to have available sometime in the 4th quarter of this year. And I think, yeah, most of the models that investors are building really build them initially around the melanoma product, because that's what they clearly can build around, and they'll start factoring those other tests as we begin to launch them and bring them to the marketplace.
I know I've seen a bunch of questions come in, and I never know if I should answer or not because a lot of them are way off base. But let me just go through a couple real quick. Is DermTech looking at doing any acquisitions? I mean, I think I know the answer. Well, actually, I don't know the answer. So maybe you can give us the answer.
We would do anything that made sense, that was really going to either speed our time to market or improve on this notion of this category that fits within this category we're creating called precision dermatology. And so we're always, looking at opportunities, and if they come, we would make them, and we're going to do something to let everybody know. But right now we're pretty happy with what the opportunities we have in front of us with our core platform.
And I know you did about a $140 million stock offering back in January, right?
That's correct.
So balance sheet's in pretty good shape right now.
Yeah, we announced on our earnings call that we have about $260 million on the balance sheet. That came from that offering. Also some ATM offering that we did, but we had some warrants that were outstanding, and the vast majority of those warrants got exercised as the stock price has gone up, and that brought in an additional $60 or $70 million of money to the company.
Now, I thought I read somewhere that you guys have some strategic partnerships with Johnson & Johnson and L'Oreal. Is that right?
Well, they're really more, we provide them with the use of our platform to help them develop their drugs. All these companies are developing drugs. Often they're targeted biologic drugs that target a specific pathway in an inflammatory disease, like say psoriasis or atopic dermatitis or lupus. And so they really want to know, does that drug work? Does it act on the target that they have? Does it improve the levels of that particular target? With the idea, most of these drugs, they work, but they often only work in a smaller fraction of patients. So say for example, in psoriasis or atopic dermatitis, the two biggest drugs there that are biologics for severe disease only work in 30 or 40% of the patients. So if you can identify markers in the skin that tell you who's likely to respond to your drug, that would be a big benefit. And some pharmaceutical companies want to understand if that's possible, so they're using our technology to understand that. We're also working on our own initiatives to look at being able to predict response for some of these very expensive biologic drugs, so you don't waste money on giving a drug to a patient that is unlikely to respond, and the patient then has a poor outcome. So we have some work going on there, and the pharmaceutical companies look at all that, and that's where we collaborate with them on.
Gotcha. A few people have asked, could you also go through primary care physicians instead of dermatologists?
We are, and we're looking at that now. Dermatologists we have to have a core foothold in dermatology. They're a core customer for us, so we started there. But there are a number of for example, integrated primary care networks, and they kind of exist to control costs in healthcare. And the way they do that is by avoiding referrals to specialists, particularly specialists that are outside their network, and dermatology is often outside the network.
Right.
So they would love to have a tool they can effectively rule out skin cancer and avoid those referrals that aren't necessary. And so we think there's a big opportunity there. We're working with some of those to bring the technology into those networks. And dermatology, actually, a lot of dermatology is practiced in primary care. In fact, part of a primary care physician's residency training involves rotations in dermatology. So in particularly areas where there's poor access to dermatologists, it's important for primary care to have tools to manage their dermatology conditions. And so we think there's an opportunity there. And so we're looking at that, and with the capital we have now, being able to access some of those other channels.
Are dermatologists would they not recommend the DermTech patch if the patient's insurance carrier didn't reimburse it? Is that usually how it works?
There are some, that's definitely, something that can hinder adoption. Dermatologists and physicians in general like to know their patients have coverage for the test they're going to receive. So, I think that's the overall thesis. As you get more coverage, you get more utilization, and then the whole thing compounds on itself. So that is an important factor. And there's been some surveys done that show one of the things that the doctors take into consideration when they prescribe our test is the patient covered or not from their carrier. And so as we get more progress with the payers, that should drive more utilization, we believe.
And just so people know, I mean, I think I did mention earlier, there's over 30 Blue Cross Blue Shield organizations, which are all part of I believe they call it the Federation. Do the Blues all tend to kind of follow each other? Three or four of the big ones support DermTech. Are the others more likely to follow their lead?
They can, for sure, and they certainly have an association where they all talk and share what they're doing. But I think they still, many of them make an independent decision. But it certainly adds credibility to have the largest Blues in the country, behind the test. And in some cases, for example, Blue Shield of Illinois is part of HCSC, which is a larger Blues plan that I think includes 6 or 7 Blues plans. And so we'll talk with HCSC, because they're largest Blues carriers using DermTech. So there's probably some advantages to getting amongst other Blues with the current Blues that we have.
I know I asked you this kind of in our pre-call and someone else brought it up. Gross margins, I don't know if you're allowed to comment yet on where gross margins might go to this year, next year, the next few years as you ramp up volume.
Yeah, it's a common question. We haven't given out guidance on gross margins, but if my CFO were here, he would tell you that, it's not about, we can generate significant margins, we believe 70% and higher over the long term. And just at the volumes we're doing today, so our run rate for in December, would mean just if we don't grow at all, we'd be doing about 35 to 36,000 tests this year. At those levels, if we just had pricing that was anywhere close to our Medicare pricing, call it $600 ASP, because Medicare pays us $760 per test, we'd already have 60 or 70% gross margins close to that. So it's just really about driving the ASP at the volumes that we're driving now. We can generate healthy margins. We just need to drive that ASP with more payer coverage.
And I assume your facility in California, you have plenty of capacity right now? We
do. We can do up to 300,000 tests in that facility when we scale up. Our current capacity in terms of people and machines is north of 100,000 tests per year.
And how big is DermTech right now in terms of total employees?
We're growing. I think we're north of 130, maybe roughly. I haven't got the latest update, but it's somewhere around there.
How big is the sales team?
So we currently have 40 sales managers. Our full commercial team's about 60 people.
Wow. Okay.
40 of those are sales managers. We did an analysis a while back, to understand how big in a sales team we should build and what kind of ROI we'll get on that sales team based on its size. And we really could go up to about 55 sales managers, direct sales managers, and get a good ROI. We could really go all the way up to, north of 75 if we wanted to. The return gets a little less and takes a little longer. But we really, as I mentioned, when the pandemic hit, we were really just starting to scale that up. We were going to go right to, that number 55 by the second quarter. But when the pandemic hit, we obviously slowed everything down. We're at 40 now, and we'll start to, as the pandemic is kind of getting more under control, we're going to start to add more sales reps during the year to get closer to that more ideal number of 50, 55.
Okay. I don't really have any more questions. I know you're a busy guy and you probably got better things to do than talk to us, but I really appreciate this. I think you are going to give 2021 guidance on the Q1 call, right? Is that what you said?
We'll have to see. It's all a function if the metrics have calmed down, because the reason we're not giving guidance is the pandemic throws all your metrics up. They fluctuate so wildly. when the COVID is up, the sample volumes change and all that. So if we have good assurance and understand that the metrics are stabilizing, then we'll give guidance. So we'll just have to see where we are at the end after this quarter and where we are with the pandemic before we start giving guidance.
So I keep telling people that, growth stocks have sold off recently, but I think they're overreacting because a lot of the growth stories like DermTech in many ways are also a reopening play. When life goes back to normal and everyone has the vaccine and people can go see their doctors, that's going to be good for companies like DermTech.
Yeah, and I agree. And I think, some people talk about there could be pent up demand for things, and that's part of the reopening. I think the important thing is investors, the health of our business is the sample volume we are generating. And what a lot of investors do when they build a model, they look at how many samples we're doing and they apply what they think a targeted ASP could be, anything close to, say, our Medicare pricing at $760. When you do that, you find our implied revenue based on the kind of volumes we're doing today is really more in the $20, $24 million range. And so that's where they're looking out. And it's really not a question of if, but when we're going to get those payer coverage. It's just a process that takes time. And so you get a compounding effect of growing sample volume and ASP. That's what investors are looking at when they value DermTech over the long haul here, is that sort of compounding between those variables, growing that sample volume and then growing that ASP.
Perfect. I'm glad you said that, because that's exactly what I've been preaching for the last couple of weeks, as people been panicking over growth stocks. So, well, John, thank you so much for joining us. Really appreciate it. Like I said, I'm a big believer in what you guys are doing, and this is a long-term hold for me. So I'll be buying more shares along the way, I promise.
Great. Well, thanks. I enjoyed talking with you. You really got a good handle on our story, and I appreciate the support. And I appreciate the support from your followers too.
You're very welcome. Best of luck, John. Talk to you soon. Take care.